We're going to resume our afternoon session, and we'll continue the theme of genomics and personalized therapy. The next set of talks will look at histologic assessments and molecular pathology. This will be done by Dr. Hechtman of our pathology department. And then we'll shift gears and look at treatment for localized disease, particularly I'm so happy to have Dr. Goodman here, back on her home turf, talking about tailoring radiation therapy in esophageal cancer. And then we have our distinguished guest from Frankfurt, Germany, Dr. Saleh Al-Batran, who will share his experience developing groundbreaking research and really how he changed the landscape for this disease with practice-changing study for pre-op FLOT therapy. And then we will finish up with Dr. Dan Coit, who will talk about, and Raja Flores, are also back on home turf from Mount Sinai to talk about surgical approaches in esophageal and gastric cancer. So with that, I'll introduce a friend and colleague, Dr. Jaclyn Hechtman, who will talk to you about molecular pathology and biomarkers in advanced esophageal gastric cancer.
Thanks, Dr. Jandigian, and for everyone for coming today. So the next 20 minutes or so, we'll talk about molecular pathology and the current biomarkers that are available for advanced esophageal gastric carcinoma. All right. The outline of this talk will be discussing first the different molecular subtypes from the TCGA, or Cancer Genome Atlas classification, and molecular correlates of those. And then we'll move on to the 3 approved biomarkers that are often tested by your pathology colleagues. So that includes mismatch repair, or MMR, immunohistochemistry, IHC, testing / microsatellite instability testing. And that's done with immunohistochemistry, polymerase chain reaction, or next-generation sequencing. Then move on to talk about PDL1, or programmed death ligand 1, and a brief overview of that and the IHC interpretation that pathologists currently use for EG junction tumors. And then HER2 and how we are currently issuing results for IHC and fluorescence in situ hybridization. So the Cancer Genome Atlas currently has 5 molecular subtypes of esophageal gastric cancer. The first one, which we're not going to talk about today, is the one that's in burgundy, and that's a squamous cell carcinoma of the esophagus. So that's almost all the tumors we see in the mid and upper esophagus. Comes with specific amplifications, including CCND1, TP63, and SOX2. The next subtype is the CIN, or chromosomal instability type, and those are most common in lower esophagus and gastroesophageal junction, and that's where we see our HER2 or ERB2 amplifications. Then below that, we've got the EBV subtype, which, as you can see in the orange, is much rarer than the others, and it has certain morphologic similarities with the case right below it, with a type right below it, microsatellite instability. So they're both poorly differentiated with high numbers of tumor-infiltrating lymphocytes, and both of them respond well to immunotherapy. And the last one is the genomically stable, which is often characterized by signet ring cells, and correspondingly has E-cadherin or CDH1 mutations as well as ROA mutations, and occurs most commonly in the stomach rather than the esophagus or EG junction. So here we have some of the morphologic correlates. TCGA subtype has been shown to influence prognosis. So on the top 2 graphs, we have MD Anderson's results, and the bottom is the Samsung Medical Center. So we can see that the genomically stable, or the signet, which often has signet ring cells, the worst subtype, EBV, is the best, and in the middle are chromosomal unstable and MSI. So the TCGA subtype and the morphology has also been associated with response to adjuvant treatment. So chromosomal instability high tumors have the most dramatic response to chemotherapy, where genomically stable tumors with signet ring cell morphologies have the least and don't really benefit from adjuvant chemotherapy. This is an example of the morphology of an EBV subtype gastric carcinoma, and what would usually tip a pathologist off to test for EBV by in situ hybridization, as seen in the bottom right, is the poor differentiation, so it's not gland forming anymore. And then there's also a lot of lymphocytes, which are the small, round, blue cells with very little cytoplasm, infiltrating between all the tumor cells. So on the bottom right, we have the chromogenic in situ hybridization, and brown is positive, and so that's the tumor cells that are lighting up for EBV. This is an example of a genomically stable subtype, and here we can see your traditional signet ring cells that you probably heard about in med school. Okay, now we're going to switch gears and talk about the 3 biomarkers that are most commonly used for advanced esophagogastric carcinoma and tested by your pathologists. So microsatellite instability is caused by the loss of function of one of 4 mismatch repair proteins, MLH1, PMS2, MSH2, and MSH6. Microsatellite instability is characterized by a hypermutation signature with insertions and or deletions and small repetitive segments of DNA, and those are called microsatellites. They're often in introns, or most commonly in introns. However, when they're encoding exons, they can be oncogenic and generate a neoantigen response. So what are the implications of finding a mismatch repair deficient or MSI high status? Often candidacy for PD-1 inhibitor therapy, but also these patients need to be worked up for potential Lynch syndrome. And in addition to that, a lot of them don't respond to traditional chemotherapies, such as 5-fluorouracil. So currently, the National Comprehensive Cancer Network recommends testing for mismatch repair or MSI in locally advanced, recurrent, or metastatic esophagogastric junction cancers who are candidates for PD-1 inhibitors. That's not entirely so easy for us pathologists to know, because when we just get a biopsy, we don't know whether or not it's metastatic or advanced. So often you guys need to request it separately unless we have the resection and it's shown somewhere else, or it's a biopsy of a metastatic site. Unlike the other molecular tests that are performed for esophagogastric junction tumors, this particular one usually does not show heterogeneity. So the microsatellite instability status is usually consistent from one sample to the others. This may not be true for HER2 and PD-L1 specifically related to this type of tumor. So the first of the 3 ways to test for microsatellite instability or mismatch repair status is PCR. This is the gold standard, but also the oldest way to do it, and is kind of falling out of favor with a lot of us. So this is done with a panel of 5 mononucleotide microsatellite loci, and you need a shift of 2 or more base pairs and 2 or more loci to call it microsatellite instability high. So of these 2 graphs, the top one is the tumor, and we see 2 bell curves in a lot of the loci. So for example, this one and this one are 2 small bell curves, as well as this one, where if you look on the matched normal, it only has 1. So this is characteristic of what we see for microsatellite instability high. So the microsatellites are contracting, and you're deleting a certain number of nucleotides in the somatic, in the tumor. The second methodology is mismatch repair immunohistochemistry. So for a result to be retained expression, which is normal, you need nuclear expression of all 4 in at least some tumor cells. There's different separate patterns that kind of tell you a little more about when it's abnormal. So for example, if you lose MLH1, you almost always lose PMS2 as well. The loss of those 2 signals an MLH1 issue, and that could be Lynch or MLH1 promoter hypermethylation in a sporadic case. When MSH2 is lost, MSH6 is lost with it, and that's an MSH2 issue, and that's Lynch versus somatic. And if you have isolated loss of PMS2 or MSH6, the issue is with whichever gene is lost, and it could be Lynch or a double somatic mutation or a somatic mutation and then a deep deletion. The third and most modern way that we've been looking for MSI status is through software programs. So these software programs include MSI Sensor, Mantis, and other separate software programs. And what these do is you take the DNA libraries that already have been generated for next generation sequencing, so KRAS BRAF testing. Then you look for either all available microsatellites or a certain set of them, and it's calculated how many are unstable against either a pooled normal or the matched normal. These are different from the other two assays because they need to be individually validated for each NGS assay that you do it on. And in this figure, we have a screenshot of an integrated genomics viewer result, and we have 2 microsatellite loci, so the stream of A's here, of adenine nucleotides. This is on the top, the coverage, and you can see a deletion in the coverage in the tumor. So there's a deletion of some of the A nucleotides in a long microsatellite for each of these 2. So these 2 microsatellites are unstable. So it's a decision between the pathologist and the oncologist for each hospital or cancer center, which assay is most appropriate. There are certain advantages and disadvantages to these 3 tests. For PCR, I kind of don't know what the advantage is, but for IHC, it's very good for low tumor purity, so cases where you have a lymph node or signet ring cell carcinoma, it works better than the other 2, and you also have knowledge of which MMR gene is not functioning. However, if you do next-generation sequencing-based software programs that will generate like an MSI result, you can also know whichever other genomic events are occurring. So it might pick up HER2 amplification or a BRAF status that might clue you in that it's not Lynch, and also like if you have a matched normal, you can screen them for Lynch or test definitively for Lynch right there. The disadvantages for IHC are that after neoadjuvant therapy, MSH6 is sometimes lost, and it's not necessarily indicative of mismatch repair or microsatellite status. And then there's also some cases where all 4 proteins are retained, but the tumor is actually microsatellite instability high, and this might be due to a putative missense mutation within that gene, so that the protein is expressed, but it's not functioning correctly. PCR has some disadvantages. We don't use it very often here. And then for next-generation sequencing, if you have a low tumor purity, you might miss microsatellite instability high cases because the normal drowns out the signal. Okay, so the next test that we'll be talking about is programmed death ligand 1, aka CD274. So this is a transmembrane receptor responsible for suppressing immune responses. It reduces proliferation of antigen-specific T cells and apoptosis in regulatory T cells. So calming the immune system down is what this expression of this usually does. PD-L1 expression in esophageal gastric cancer has been linked to a higher likelihood of response to pembrolizumab, as you can see here. So 15% if PD-L1 is expressed versus only 6% if it's not in this paper. And the NCCN recommends for PD-L1 IHC to perform it on essentially the same group that you would as mismatch repair or microsatellite instability. This kind of test, the only way to test for this is IHC, and it's used by a couple different manufacturers. However, there's only like one scoring system. So this scoring system requires 100 tumor cells to be present, and then a combined positive score is calculated, and we'll go over that next. But essentially, when the combined positive score is greater than 1, it's considered that PD-L1 is expressed, and those patients are eligible for PD-1 inhibitors. So it's important to know the tumor type for determining PD-L1 status, because determining PD-L1 status for EG cancer has a different methodology than you would for lung or GU tumors. So for esophageal gastric tumors, we use the combined positive score, which the way that we calculate that is we evaluate the number of PD-L1 staining cells, including tumor cells, lymphocytes, and macrophages, divided by the total number of just the tumor cells, and then multiplying that fraction times 100 to get the percent. So you can actually have above 100% in this sort of calculation. So this is different than the way that pathologists are scoring lung cancer. And that's why if this is a metastatic biopsy, we kind of need to know what kind of tumor this is. So if it's a CK7-oma, we need to know, I guess, if you guys are thinking it came from the stomach or esophagus. This is a couple examples of PD-L1 in esophageal gastric tumors. So here we have our tumor on the left, and on the right, we can see a cohesive group of cells. These are all the tumor cells, and there's membranous staining, which we often see in the tumor cells. This is positive for PD-L1 expression. However, this is a separate case, and we only see a few cells over here staining, not as many, but this would also be positive. And it's in a different proportion. It's in a different type of cell. These ones are lymphocytes and macrophages, and not the tumor cells. So there are a couple different patterns, and there's not much required for it to be positive. The last type of testing that we'll go over is ERB2 or HER2 testing. So the NCCN recommends ERB2 to be tested in all patients with suspected or documented metastatic disease. Unlike mismatch repair status, there's a lot of heterogeneity with esophagogastric tumors and HER2. So often if a patient has a biopsy and an initial negative result, here at MSKCC, we'll go ahead and test later samples, knowing that sometimes one small sample might be negative, but another part of the tumor and another sample that you guys sent might have some HER2 overexpression. So as we heard before, HER2 overexpression amplification is most associated with the chromosomal instability subtype, which is often associated with Lorenz intestinal morphology. In 2017, JCO published new guidelines for HER2 testing in esophagogastric cancers with the cooperation of the College of American Pathologists and ASCO. So first, IHC should always be performed. It should never jump to FISH first. So when you have IHC, you have a few different patterns. We look for strong, complete basolateral or like membranous staining in at least 10% of tumor cells in a resection, and only a small cluster is required for a biopsy in comparison. And if you have strong staining, you're done testing, and that's a positive sample. If it's faint or negative, then that's negative. However, if you see this pattern of staining that's weak or moderate, we usually call that equivocal, and reflex testing to in situ hybridization is required for cases that are equivocal, or 2+ is the other way that we word equivocal. So these are some examples of HER2 IHC that we often see. In the one called A, where the two arrows are, you can see some staining. It's on the weaker side. This one we would give equivocal to, and this one needs HER2 FISH or CISH. In B, we have a little bit stronger. C is a positive one, so this one would just absolutely need nothing left. And so this person would be eligible for trastuzumab if it's advanced. And then in D, we have some of the heterogeneity that we see between samples, but even in a very small number of tumor cells, you can see where the asterisk is, there's no staining, where there's one arrow in D that is just like a tiny bit of staining, where there's 3 arrows, there's strong staining, and where there's 2 arrows, it's moderate. So this person might have a mixed response as well. We typically, or I guess it's not required currently, to say what % of tumor cells in IHC are positive. It's just a positive or negative result, because treatment is either to treat or not. Currently for HER2 FISH is only performed, as we said before, when IHC is equivocal, not as a first-line thing to do. The HER2 is looked at against the chromosomal enumeration probe 17 ratio. So if you have twice as many HER2 gene signals compared to CEP17, or more than that ratio, then it's positive. So for example, C is an example of a ratio greater than 2, so the red signals are HER2. And the green signals are the chromosomal enumeration probe for 17, which is the chromosome that HER2 is on. However, if you have a HER2 copy number of greater than or equal to 6, it's generally considered also positive. So that's B, where you have a lot more copies of CEP17, but also a lot of copies of HER2. So the take-home points for this lecture are that the TCGA molecular subtypes correlate a lot with histology, and they're also associated with prognosis and treatment response. The main pathology add-ons right now require input from oncologists to know when a tumor is at a stage where they'd be eligible for treatment. And these include mismatch repair IHC or microsatellite instability DNA testing. So these help you assess whether or not a patient might have Lynch or is a candidate for PD-1 inhibition, PD-L1 IHC for PD-1 inhibition, potentially EBER-ish if the morphology is suggestive of it, and these cases have a better prognosis, and then HER2 IHC and FISH if equivocal, and patients are eligible for HER2 inhibitors in those cases. Thank you.